Hi everyone, my name is Matt Budarazi. I'm a hospitalist at Maine Medical Center. For the past several weeks, I've been giving this refresher on pulmonary ultrasound covering pneumonia. We've been doing this as our COVID cases have been rising. This was designed to help anywhere from our novice ultrasound user to our advanced ultrasound user, so hopefully there's something in it for everyone. We are going to discuss probe position and a few example protocols. We're going to take a brief look at two cases that demonstrate why pulmonary ultrasound is useful. We're going to have a brief discussion about how ultrasound can help us in COVID cases beyond just looking at the lung. And then we're going to go through several abnormal lung videos that demonstrate different pathologies seen in pneumonia. And then we'll wrap it all up with a brief review of COVID data that's been published so far and take a look at some ultrasounds of a COVID patient. First up, we have probe positioning. Standard view has the probe placed between two ribs. So you have a rib, subcutaneous tissue, rib, with the probe in between. All probes have some sort of an indicator dot, which corresponds with an indicator on the screen. In our case for pulmonary ultrasound, we place that indicator facing the head so that if we're reviewing images later, we always know our orientation. Looking at the screen here, we have lung parenchyma, rib shadow, which would correspond with this lower rib, pleural lining, lung parenchyma, rib shadow, corresponding with the superior aspect of the probe. This is a figure taken from the Point of Care Ultrasound book by Dr. Soni. I like this figure because it quickly reminds us about our lung anatomy and orientation. So anteriorly, you're going to be interrogating the upper lobes, laterally, the middle lobe, and posteriorly, the lower lobe. The figure also is a good representation of, as you move the probe around the chest wall, you want to keep it perpendicular to the chest wall, trying to go directly in if possible with your sound waves. Perpendicular, perpendicular. So now looking at a couple protocols. This first one is the blue protocol, which is 4 points. Point 1 is the anterior chest, point 2 is the lateral chest, and then 3 and 4 are the costophrenetic angles. It's a good demonstration of the two main windows we get in pulmonary ultrasound. The first window being what we already looked at, rib with rib shadow, lung parenchyma, rib shadow. And then the second window being that at the bases of the lungs, where we have lung followed by diaphragm and then abdominal contents, where we get to see more lung sliding into view as the patient takes a breath and the diaphragm drops. This is also a useful protocol in bedbound patients or patients that you can't sit up for a better chest x-ray or for a better exam. You can expose these posterior lateral points by having them move their arm across their chest and roll their shoulder to the opposite side of the bed, and that really opens up those windows. The second protocol we're going to look at is called the Blue Plus protocol. I'm sure there's other names for it, but essentially it's a 12-point protocol with 6 points per lung, with the lungs divided into 3 sections. So anteriorly you have an upper and lower, laterally upper and lower, and then posteriorly again an upper lung field and a lower lung field. They found that this had a 95% sensitivity and 87% specificity for consolidation and atelectasis. Note that this doesn't say pneumonia. You still need to use your clinical reasoning to decide if this finding is a pneumonia. The lower lung fields are what drive most of this sensitivity and specificity, and I think that it's important to note that a lot of the COVID reports that are coming out show lower lobe predominance, so again, the lower lobes are going to be the most helpful. So now we're going to take a look at how these windows appear on the ultrasound. So first on the left, we have a normal patient. So we have chest wall or soft tissue, rib with rib shadow, rib with rib shadow, and then lung parenchyma in the middle. So what's happening is that sound waves are traveling through the chest wall, the soft tissue, and where they transition from soft tissue to lung parenchyma, which is filled with air, you get creation of artifacts because the air does not bounce sound back to the probe. So the pleural lining gets represented as this shimmering, hyper-intense area that slides back and forth. When you have normal air or normal lungs filled with air below the probe, you get an image artifact created of that pleural line where it gets recreated down the screen as a reverberation artifact, and this is called an A line. So A lines come first, they're normal. In the second picture, we have demonstration of another artifact called a B line, which are these vertical lines coming off the pleura. So again, soft tissue, chest wall, rib with rib shadow, rib with rib shadow, and another rib with rib shadow. Patient's breathing, so you have sliding lung parenchyma back and forth with the pleural line, and coming off that pleural line is an irregularity, so these B lines. And B lines get created when there's any kind of parenchymal process or interstitial disruption in the lung parenchyma below the probe. So we're talking about pulmonary edema, pneumonia, interstitial lung disease, ARDS, anything that's going to disrupt the parenchyma is going to make a B line. So just taking a second to look at air. So if you have a probe with no gel on it and you stick it in air, you get the same things, reverberations. If you add gel, you get the kind of homogeneous gray like we see in our lungs. Here are some more examples of A lines and lung sliding. So looking at the first video again, you have chest wall, soft tissue, rib with rib shadow, rib with rib shadow, lung parenchyma in the middle. You have a nice smooth contiguous pleura sliding back and forth with reverberation artifacts, the A lines below. Same thing in the second video, smooth contiguous pleura sliding back and forth, an A line below, ribs on each side. And same thing, different ultrasound, rib with rib shadow, rib, rib shadow, and again, smooth contiguous pleura sliding back and forth with A lines. You probably noticed that I said smooth contiguous pleura 3 times in this slide. That's on purpose. So when you're looking for pathology, you're looking for aberrations in that smooth pleural line. So that's going to be a hint that something is different if you're lacking that quality to your pleural lining. So with pulmonary ultrasound, we're trying to answer the basic question, is there a parenchymal process? So thinking again about our A lines and B lines. A lines are seen in normal patients, so we're looking at air below the probe. What else do you have air below the probe in? Well, COPD and asthma. Pulmonary embolism, if there isn't anything else going on, or a lung infarct to go along with it. And pneumothorax. In the case of pneumothorax, the lung is no longer sliding as the lung is not inflated to the chest wall. Thinking about B lines, we're thinking about interstitial processes, parenchymal disruption, so things like pulmonary edema, ARDS, interstitial lung disease, pneumonia of all kinds. These are all going to create B lines. Now taking a look at the second window at the claustrophrenic angle. This was the 4th point of the blue protocol, taken at the base of the lung. It's also called the posterolateral alveolar pleural syndrome point, or PLAPS. This has a very high sensitivity for lower lobe processes. It's essentially the posterior axillary line at the base of the lung. And so what this view allows you to do is visualize lung and abdomen at the same time. So you have lung, diaphragm, abdomen, and as the patient takes a deep breath, the diaphragm's going to drop and more lung should come into view. And what you're paying attention to is the transition point between the diaphragm and the lung, looking for any irregularities and looking for that smooth pleural line coming into view. Here we have two videos to demonstrate normal windows taken at the claustrophrenic angle. In both of these, we have what's called the curtain sign. So both patients, we start with liver in view, patient takes a breath, and then lung slides into view as the diaphragm drops and the chest expands. Things to look at are the transition from abdomen to lung, right there. Looking for pleural effusion, looking for changes in the pleural lining, and looking for consolidation. So it's that point, that transition, looks nice and clean. Next, we're going to take a quick look at two cases that demonstrate why we should be using pulmonary ultrasound in our patients. For the first case, we have a patient coming into the emergency department. They're bedbound at baseline. They're having a new oxygen requirement and increased sputum production. The chest x-ray demonstrated a new right lung abnormality, and they were started on antibiotics for treatment of a pneumonia. The next day, an ultrasound was performed at the right base. So this demonstrates pleural effusion with multiple loculations. You can see that the chest x-ray doesn't really do what we see on ultrasound justice. And the reason being there is that this is a portable chest x-ray. The patient is bedbound, so they're laying pretty flat. They can't sit up. That's going to give you poor views at the bases, including hiding things like this. So again, moderate pleural effusion with lung, and then multiple loculations in view. So this patient ended up needing a chest tube for definitive therapy of their pneumonia. In the second case, we have a patient in the middle of a 2-week complicated admission for heart failure and AKI. They've had increasing fatigue for a couple days, a rising white count. So a chest x-ray and UA are performed, which are unremarkable. Here's the chest x-ray on the right. No focal infiltrates identified. Creatinine was worse that day. INOs and weights were unfortunately not very helpful. You're considering diuresis versus another cause. This is an ultrasound of the patient's left base. What you see here as the patient takes a breath is areas of aerated lung, and then the breath followed by areas of consolidated lung, that's darker spots. So now taking an extra minute to discuss these frozen. On the right we have the more normal appearing part of the video. So you have rib with rib shadow, lung parenchyma that looks mostly normal. The pleural line is thick and it's not continuous, so there is a break here in it. And as the patient was breathing, this more obviously abnormal area slides into view. So you lose the continuous pleura, you have another density here, and then this stepped off hyperintensity. So what is happening is that the sound waves are traveling down, they're getting through the chest wall, and then now instead of hitting aerated lung, they're hitting another density. So you have a consolidated lung here. And so the border of the more densely consolidated lung now is where you get the transition from denser tissue to aerated tissue, creating the stepped off appearance here of what essentially makes up the pleural line in the other video. So in this patient's case, I ended up calling this a small pneumonia in the setting of the fatigue and the rising white count, and started them on antibiotics and ended up actually giving them a little fluid. Next day, creatinine was better. They felt a lot better. White count was coming down. Again, something else that wasn't really picked up on the chest x-ray. Next, we're going to speak briefly on how ultrasound can help us in relation to COVID cases. So first, for those of you who haven't tried this yet, auscultating with a stethoscope when you have a PAPR on is pretty much impossible. You can't hear a thing. So the ultrasound is going to give us an additional way to evaluate the patient day to day. We're going to look to limit exposure to these patients throughout the hospital. And by what I mean by that is, if we're not ordering as many x-rays and CAT scans, we're decreasing the amount of time these patients are traveling throughout the hospital. And then you're also looking at workflow perspectives as well. It takes up to 30 minutes to decontaminate an x-ray or a CT. And then additionally, we want to use our ultrasound to recognize pulmonary complications and progression of disease. So do you see evidence of ARDS with multiple B lines coming up all over the lungs? Are you maybe going to pay a little more attention, or if their oxygen slowly drifting down that day? Looking for enlarging consolidation. Maybe you need to broaden your antibiotics for secondary pneumonia coverage. Is there a new pleural effusion, which is going to need intervention for diagnosis on? Next up, we have several videos of different common lung abnormalities seen in pneumonia. Starting with B lines. So the first video on the left, we have multiple B lines coming off of a fairly smooth pleural line. 2 ribs with rib shadows. Second video, same thing, multiple ribs, multiple B lines coming off of the pleura. And third video, just another example of the same thing, a couple of B lines in field with sliding lung. So for the remaining majority of the videos, they're all taken from the claustrophrenic angle posteriorly at the PLAPS point. So first we have small pleural effusions. In each of these cases you can see diaphragm and liver, and that's moving out of view as the patient takes a breath, and you see very small pleural effusions in all 3. This one, there's even a tiny consolidation too, with the B line coming off. Next we have a little bigger, we'll call this a moderate pleural effusion. So again, liver, diaphragm, taking a breath. You don't have nice lung sliding into view. Instead you have dark black indicating the fluid. An example of a loculated pleural effusion with tethering to the diaphragm. Larger pocket here. Another loculated effusion, again diaphragm, liver, taking a breath. You can see the diaphragm drop. There's no good visible lung in view. Next we have what's called subpleural consolidations. Now these are being found pretty frequently in the COVID patients, both in the literature and here at Maine Medical Center. So to go through them one by one, here on the left, smooth pleura. You can see this denser consolidation. It's very small with a B line coming off. So that was the subpleural consolidation. Second video, you have the dark circle, like almost like somebody took a bite out of the pleura with confluent B lines below. That's another subpleural consolidation here. Third video, same thing, like somebody took a bite out of a big confluent B line with a black circle. And then this patient also has kind of more normal looking lung at the end of the video with A lines. And third patient, another subpleural consolidation. Right here. Next, this video just demonstrates hepatization of the lung. So as the lung fills up with pus or fluid or what have you, it's going to become denser, and eventually it can even look like liver. So you can see that there's minimal difference between the echogenicities of these two structures. The diaphragm is in the middle. It's liver, diaphragm, lung. Next, we have the shred sign, which was demonstrated in one of our cases above. So we'll start with the center video on this one because the one on the left is more complicated. We have liver, diaphragm, taking a breath. You have the hyper intense border with consolidation above, aerated lung below. So chest wall, instead of a smooth pleura, you have more dense structure, so it's still darker with a new border where denser tissue meets aerated tissue. Same thing here. Subcu tissue, chest wall to inside the chest cavity, small pleural effusion, and then darker consolidation. And along the border of the consolidation or the denser lung, you have the bright lines interpreting the sound moving between denser tissue to aerated tissue. Denser tissue, aerated tissue. Video on the left, we have same thing, denser tissue, bright line, aerated tissue with a different part of the lung with an A line. Here's two videos just with examples of air bronchograms. So as the lung gets denser, you can get air bronchograms here and here. This video is an example of a dynamic air bronchogram. So this little shooting star-like thing that slides in and out of view as the patient breathes. This is just the probe plane moving up and down a bronchus to create that moving effect. So finally, we're going to just look at some data regarding COVID that's been published, and then go into some ultrasounds of an example COVID patient. So the first study out of China had 20 patients. They did 12 zones per patient, and they really just outlined where they were finding things and what they were. So the majority of the findings were in the lower lung fields. They found B lines in 40% of the fields, followed by discontiguous pleural line, subpleural consolidations, and the air bronchograms within those subpleural consolidations. Interestingly, they found pleural effusions, small ones that were localized to the subpleural consolidations in about 10 to 20% of cases. This is not the same as a contiguous large pleural effusion that you're used to seeing in a pneumonia patient, which is not being demonstrated, and that is consistent with prior viral pneumonias. So RSV and influenza also do not have large pleural effusions unless there's a secondary bacterial pneumonia at play. Another thing they looked at is poor blood flow in the lesions, which is not something we're typically doing here or familiar with. I think the only one thing to note is that these were percent of zones interrogated, not the number of patients. So when they say 40% had B lines, they're talking about 40% of the zones. And remember, there's 12 zones per patient. So we kind of lose out on, did one patient just have B lines in all their fields, and that skewed the data or not? This other paper was really just a letter using a 12-zone protocol, and they reported very similar findings, with the additional note that B lines were seen early, subpleural consolidations later, and that people actually got better and had A lines at the end. So next we have several videos taken by Dr. Yale Tong Chen of himself after he received a COVID diagnosis. He is an emergency medicine physician in Madrid, Spain. So what I'm going to do is pause for each video and give you all a chance to think for yourself what you see, and then I'll describe what findings there are. All right, so day one. So what we see is the patient taking a breath, abdominal contents, no evidence of pleural effusion, smooth contiguous pleural lining with an A line, no B lines, looks pretty good. Day two. So a couple things to note. So diaphragm there. Pleural lining is a little thick, no irregularities, a couple B lines coming off, and a small pleural effusion. And this is, we're talking very small, a half of a centimeter. So this is just the tip of the base of his lung. Day three. So on day three, we have a little bit larger pleural effusion. The pleural lining is not as contiguous. There's a little bit of a dip in it here. No B lines though. Day four, pretty similar. Some more evidence of the pleural lining being less contiguous there. Little break in it. The B line coming off it. Now on day five. Here we have multiple B lines at both bases, though at the deepest part of his breaths you do catch some A lines. He's got thickened pleura with evidence of irregularity in a couple places. Consolidation there. Some darker subpleural consolidation there too. Day six. Some more of the same. Multiple B lines throughout. A lines still in places as well. Some pleural irregularities. Day seven. So very similar again, some B lines, a couple A lines, thickened pleura. And then day 8 and day 9 are pretty similar. Just multiple B lines. No real big difference. Hopefully this has been helpful for everybody. I've included a couple general resources here. First is Core Ultrasound, which is a website with a podcast, instructional videos, lots of content that can help you learn ultrasound and answer questions. The POCUS Atlas is another great resource, which includes an image database as well as what's called the Evidence Atlas, where they review literature and give you things like likelihood ratios for different parts of the ultrasound exam. And then the book Point of Care Ultrasound by Dr. Soni is a great book that we use as the structure for our ultrasound elective with the residents. Here are two other good refresher videos for COVID ultrasound. The first is a very brief 5-minute overview of viral pneumonias. That's a really quick watch and could be good right before you grab the probe. And then this is a slightly longer 20-minute video called Focus for COVID-19 by Joseph Minardi. Both of these are pretty good and could be helpful for people. And that wraps it up. Feel free to reach out to me at buddhaM@mmc.org with any comments or questions. Thanks to Cliff and Monica, who are other ultrasound faculty, for their hard work and videos that were used in the presentation. And a special thanks to our administrative and support staff at MMP Hospital Medicine. They've put in hours of hard work to keep things rolling in our group, and they're doing a tremendous job. So thank you everyone for listening, and stay safe.